Hello, my name is Dr. Sally Pezaro, and I'm very grateful to be here today speaking to you about hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders during pregnancy, birth and beyond. I'm a midwife by background, and I first got interested in this topic when someone with hypermobile Ehlers-Danlos syndrome at work talked to me about, what would happen if someone was pregnant with this condition, and I really didn't know, and I wanted to know. And I realised this was a very underserved community, underserved population of people that needed help, needed support, needed evidence to support their care and pregnancy journeys. So today I'm going to share the journey of my learning and the journey of where we are and where we're going in terms of finding out more to help this population. So we started off by publishing a care considerations, if you like, in the British Journal of Midwifery. We looked around at all the literature at the time and put a midwifery lens on it, a childbearing lens on things to see, well, if this happens to the body, what would happen during pregnancy? And we also published an update to that a couple of years later. And these updates have helped people around the world. They download them for free and take them to their healthcare worker to learn more about these conditions and help them progress. So I'm going to share some of the things we learned from reviewing the literature and then take you forward on our journey in collecting primary data as well. So in terms of an overview, there's a massive adaptations to connective tissues when you grow and birth a baby. Your body needs to change, it needs to adapt. And if you have connective tissue problems with that, then obviously the hypermobile Ehlers-Danlos syndrome can affect the body and the pregnancy in various different ways. It's no longer considered rare, with the prevalence of about 1 in 500 people having these conditions. And it takes on average a few years for people to get diagnosed. So it's not rare, but it's rarely diagnosed. And people can get very frustrated trying to tell their doctors, tell their midwives that they have these concerns, and their diagnosis seems very far away. And those concerns can be exacerbated over a lifetime. So, for example, when you're a child, going through puberty, then going through growing your family, and then getting older, everything can change. But pregnancy can be that catalyst for change, where things are really putting pressure on your body, and so they may exacerbate or reduce symptoms for you, change them in different ways. So there's some significant symptoms that are significant in pregnancy, and these things we know about. So cardiovascular and autonomic dysfunction are quite common, purely because your blood volume is increasing in pregnancy, so that puts extra strain on that system. Bowel dysmotility can happen, and also your orthostatic intolerance, so standing up, sitting down, feeling faint, feeling dizzy, and having migraines as well. Urogynecological problems, when your bladder and everything is trying to get rid of pass more urine, more frequent urination, and your body's trying to adapt to that. Also the mast cell dysregulation, increases of pain and anxiety and depression. There's also increased rates of fatigue, which can be difficult because these are things that everyone experiences during pregnancy potentially, but it can be exacerbated in these conditions. Sleep disturbance, and also an increased diagnosis of psychiatric disorders, including autism spectrum disorder and suicidal ideation. So there's a mental health aspect as well as a physical health aspect to think about here. And what we found is that in the antenatal period, pregnancy is generally well tolerated, although people can experience mobility issues. There's been some rates of lower fertility reported, but that's not necessarily coming out in other studies. And symptoms of pregnancy can be exacerbated, but they can also be helped, for example, in other ways. So everybody's different is basically the message. But those pregnant with hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorders, obviously experiencing that joint laxity. And when you've got pregnancy hormones also increasing joint laxity, you've almost got a double whammy on people when they're trying to increase their mobility during pregnancy and stay healthy and well. And equally, because the soft muscle tissues are affected, there might be an increased rate of vomiting in early pregnancy because you've not only got the pregnancy hormones, but also the connective tissues are more lax. There's also some other studies which have brought out other things, but they're quite rare. And, again, with the gastro reflux, everyone might experience a little bit of heartburn during pregnancy, but this can be exacerbated again because it's those internal systems affected by connective tissues that can cause problems in those areas. So in terms of management during the antenatal period, we were thinking about what could we do as healthcare professionals when we don't really know that much about the condition, but we know that these issues exist. And we're thinking about, again, all the things that affect the body when you've got connective tissues and lax tissues and soft tissues. So varicose veins are quite problematic in these populations, and wherever they are, they can really be benefits to attending a vascular service or using hosiery, tights and stockings to help with those. Reflux and hyperemesis can be managed via usual treatments but might need to be started earlier. And if you are going to have problems with your joints early on, if you're not already engaged with physiotherapy, that can really help in terms of bracing, other aids that can help you support your joints during pregnancy. Anything else can be managed via obstetric-led care, potentially surgery in some cases, but obviously that's an extreme example of things. And then we obviously have to look at POTS, so this is postural orthostatic syndrome. And this affects a lot of people who have HEDS and HSD. When we're looking at the body in general in terms of POTS, we're looking at sitting and standing positions being challenging in terms of dizziness, fainting, etc. But with pregnancy, your blood volume increases by like 40–50%. So that changes POTS. And a lot of people say that POTS actually gets better in terms of their symptomologies when they're pregnant. We know that they that can exacerbate in certain points in pregnancy, but overall people tend to say that it can help pregnancy. So it's more like your body's more likely to decompensate for things as well. So trying to right the wrongs of what's happening in your body. And there's some overlapping conditions as well that can't be ignored. And these are all covered in our paper, which you can read and share around with your clinicians that could be helpful. The management of POTS in pregnancy, unfortunately, there's no uniform guidance, although there is some more recent guidelines that have been published by Morgan et al., which can be looked at, and we've not completely reviewed those yet, but they are the best evidence-based recommendations we have at present. But still, they are not concrete in terms of there's not much you can do in terms of these things, but tailored exercise appears to help. First line therapy, oral hydration, so again monitoring fluids and seeing how you can counteract any negative responses to those fluid changes. Beta blockers can be used, and medications can be prescribed preconceptually to reduce symptoms as well. And then we'll talk about the intrapartum care considerations. So this is when you may be actually birthing your baby, and the build up in active labour can be slow for people childbearing with hypermobility spectrum disorders. And this kind of makes sense when you think about the tissues and the joints being hypermobile and hyperlax, letting a baby shoot through the birth canal much more quickly than typically we would expect. Also, the labour starting off can be very irritable, again because the body is trying to work out what to do, but the smooth tissue doesn't behave like in a typical way as we would expect. So again, those early precipitate births, very fast births early on, might seem quite irritable and last for days and days and days, but then all of a sudden the birth happens really quickly. There's a long build up, almost to 0 to 60 then, going with a really fast birth. We also know that there's increased risk of premature birth. Again, this might be because the sac around the baby is also made up of tissues which are affected by the hypermobility spectrum disorders and hypermobile Ehlers-Danlos syndrome, and the chorion and amnion could be affected in whatever ways. So that could be why we're seeing more and more premature births in these populations. And increased risk of fetal malpresentation. So, for example, we would want a baby to be head down, with its head in a good flexed position prior to birth. But because perhaps, again, the uterus made of soft tissue and connective tissue is more lax than is typically expected, it may not hold the baby in the same position and allow that baby to move around much more than it typically would otherwise. And so there can be breech birth or malpresentation with babies more frequently, which makes birth more challenging because it's not in the optimal position. In terms of mode of birth, there's really not any reason anyone with hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorders shouldn't birth their babies vaginally. But other research has classified it as high risk. However, I'm not really convinced by that research, and I think it's still more about individual choice. Especially if you're thinking about precipitate birth, very fast birth, you need to think about where am I in relation to my nearest health centre? Where am I in relation to the community setting versus a rural setting? Do I need to plan for birth outside of hospital? Do I need to plan for birth in hospital? And then in terms of mode of birth, it really depends on obstetric complications at the time, rather than the risk of simply having one of these conditions. There is an increased risk of some bleeding, but that's throughout pregnancy, and we don't really know why. So that needs to be managed in whatever setting you're in. And also, if episiotomy is indicated, that's when we make an incision in the perineum, then it may be that other people want to go for caesarean section there rather than have an episiotomy, because we don't know how those soft tissues are going to behave in terms of healing, in terms of tearing, and in terms of coming back together the way they need to do so. We know that there's an increased risk of perineal trauma and also lacerations, and where the tear goes between the vagina and the rectum can be more problematic than having a caesarean section and being able to manage that in a much calmer way. Again, if someone has POTS, then the decision in relation to labour can be based on obstetric considerations, but there are other considerations with POTS to think about when someone is giving birth. There's also anaesthetic considerations. So we know that local anaesthetic in particular can be ineffective in these populations. So that means if we're doing any episiotomies or we're doing any localised work, we have to think about that anaesthetic potentially not working or needing higher doses in those cases. And you'll see later on when I share some stories, people haven't been listened to in that sense and haven't been believed when they've said, I can still feel things. So we really need to get to grips with that more widely in healthcare. Also, we know that EDS has been associated with cerebrospinal fluid leaks. So if you're having any spinal fluid or anaesthetics in your back, we know that can be problematic, not only locating the spot where it needs to go in and siting that anaesthetic, but also when it's sited, fluid leaks coming about and causing headaches and real problems there. In terms of POTS, epidurals can be really useful because they can reduce stress and therefore reduce pain, and then it help POTS patients much more in terms of their symptoms when they're birthing. Also, if we ask people to listen to their bodies and birth their own babies as they're ready, so spontaneously pushing when their body pushes rather than us telling them to push, then people avoid holding their breath. And so people go with their natural body flow, which can really help with POTS. But of course, if you're holding your breath and pushing down with POTS, that can cause real problems in terms of your symptomologies. So it's really about getting the positionality right, positioning yourself how your body tells you to, and everybody facilitating that as required. And then when it comes to pushing, you'll let your body push your baby out rather than someone directing you to. And then your symptoms can be managed better. Early analgesia as well can help, again, because you're calming the environment, you're reducing that stress, which is going to improve symptomology. So again, all the calming birth environments that we need can really help symptoms. They're not just nice to have, they're actually interventions which can reduce symptoms, problematic symptoms. And then after the baby's born, we need to think about people's struggle from recovery from birth, that problematic healing that occurs, both physically but also psychologically. In terms of physically, we're thinking about tissues which are difficult to heal. Not only difficult to heal, but when they do heal, they can heal in overlapping ways or problematic ways, and that scar tissue can really be problematic when people do heal themselves. And we have to think about hemorrhage and deep vein thrombosis as well, and problems with perineal tearing. So diet's really important in terms of high fibre diet, fruit and vegetables to help that with that healing. Lots of fluid hydration, etc., to help that healing. Also, when we're thinking about pelvic healing, we're thinking about what actually has occurred in the pelvis. Is there any underlying prolapse? Did any tears go into the urethra? Did anything happen that we wouldn't typically expect, but we still should examine for, or look for at the time to go through that healing process and help people there. And people with chronic girdle pain, which they may have had in pregnancy, it doesn't just go away instantly when the baby's born. That's going to be long term, and then of course postnatally you've got a baby to look after as well. So when you're trying to parent and you have increased joint laxity that doesn't go away immediately, you're thinking about how am I going to parent, how am I going to be mobile enough to look after this baby. So we need to think about all of those things in the postnatal period. We can use sutures which don't dissolve and are left in for longer. So for example, a typical person having a baby or having sutures could have their sutures dissolved or taken out, maybe a week or two. But here we're saying at least 14 days, leaving those sutures in to make sure that wound is really adherent and adhered to each other, to the sides in a proper way. And obviously people who've had problems before obviously have disadherence, so when the wound comes apart, and we need to be keeping things together for a lot longer. And we're talking about with the pelvic girdle pain as well, people can have as a last resort steroid injection treatments to help with that there. And then in terms of the multidisciplinary working, we need lots of people involved, rheumatology teams, pain teams, physiotherapy teams. They can be useful in the management of that. But frequent joint locations obviously become difficult when you're caring for a baby and bonding with your baby. And breast or chest feeding can be problematic, especially if you are having to stay in one position for a long time. However, you decide to breastfeed, staying in that position could be problematic. And if you have POTS, breastfeeding or chest feeding, human milk feeding basically, can really, really improve your symptoms, because it's got that diuretic effect and anti-diuretic effect and therapeutic effect when you're feeding your baby, and obviously the benefits to the baby as well, but you feeding can really help. So they're the kind of things that we've found that can be supportive in terms of the literature. And again, one study says that people needed to stay longer in hospital than average. But again, this study was done in America, where the maternal and neonatal mortality rates aren't great for a well-developed country. And it's not really clear why they stayed in for longer, whether that's just cultural or necessary. The authors of the study say that EDS is a high-risk condition, but they don't really distinguish which of the subtypes are included. So hypermobility spectrum disorders, we know, are the most common, but they're not necessarily the most dangerous or the most problematic in terms of symptomologies. So that's something to consider when we're looking at those research findings, and when we're deciding which evidence we use to inform our practice and which evidence we use to discount other things in general. So then, thinking about the baby has a 50% chance of inheriting the condition because it's autosomal dominant pattern of inheritance. But we don't really want to be examining babies at birth specifically for this, or diagnosing anybody at a very young age. However, if you do see, or a clinician sees, clicky hips or unusual skin behaving in unusual ways, considered doughy, bruising easily, splitting easily, it's really important to document those things. Not only because obviously bruising could be construed as problematic in other ways, but if you're seeing these things early on, then they can be monitored and recorded for later consideration if a diagnosis is to be made. Prematurity and floppy infant syndrome can be a thing with newborn babies, so consider joint support in anything you're doing, and also think about what you might need in terms of anticipating a neonatal resuscitation or a neonatal support post-birth. And then in anything, as always, documentation remains paramount with everything you're doing. So we went on from those initial reviews of the literature, where we pulled all the literature together to think about how these conditions might affect pregnancy, and what we can do in relation to them, to think about how we can understand hypermobile Ehlers-Danlos syndrome in the context of childbearing, talking to people who've been through birth with these conditions, either knowing they had these conditions afterwards or before. And we use these to create stories, and they're on the left there, to educate people on what it might be like to have these conditions, and what we might be able to do as clinicians to enhance clinical education and clinical practice. So I'll take you through some of the things we found. So we had 40 narratives, there were so many people come forward for interview, and we're really grateful to everyone that did. But in the end, we capped it at 40 because it was a really, really lot of data we had to look through. The participants were aged between 25 and 55. Lots of births covered from different countries: UK, USA, and Canada and Australia. I think it was Australia. No, actually, just the three. And we found that it affects 1 to 20 pregnancies globally. This paper was where we said, we know what the general population prevalence is, but what about pregnancy? And our crude estimates work out about 1 in 20 pregnancies are affected. And some childbearing experiences are very low risk, some are quite high risk, and anything in between. Some people have had great experiences, some had poor experiences. But basically all of them perceived a lack of preparedness. No one was prepared for what could happen. No one had strong clinical knowledge in this area, and there was a lack of awareness amongst professionals about what was needed, and that's what they told us. So most participants recounted a worsening of experiences during pregnancy and postnatal complications, but some obviously said things got better for me. Anaesthetic was often ineffective, and we know that anyway. And for many people, a long latent phase of labour turned into rapidly progressing labours and births. So like I said, things start off very, very slow, very, very niggly for days and days and days, or even weeks. People think, is labour ever going to start? Am I just getting these mild contractions for nothing? Am I in a lot of pain but not getting anywhere fast? And then all of a sudden, birth comes 0 to 60, and that's what they were telling us. And then because of that, maternity or perinatal staff were very panicked and weren't prepared for that, because a lot of the time, especially if you're a first-time birther, then they might say, well, we've got a long road to go. You need to go and have some paracetamol, have a bath. Labour is long, and then all of a sudden a baby would be there, and they wouldn't be prepared for it. It'd be outside their typical experiences and comfort zones. And then poor maternity care resulted in disengaging from services, trauma, stress, and anxiety, and actually an avoidance of future childbearing. Some people said they'd never do it again because of the experiences they had, which was really sad. So here are just some of the quotes that were shared from people who spoke to us. Some people said they were taking off work, they had hip pain, they were unable to walk, they were crawling to the bathroom at night. Other people had bleeding, they thought, they had a history of miscarriage, so they had some scans, but people just said, oh, it's fragile membranes, put it down to EDS, but no one really knows much about that. And other people say, and this is my favourite quote, I remember the junior rheumatologist saying, you're not hypermobile because you can't touch the floor. And I'm thinking, I'm 8 months pregnant, of course I can't touch the floor. That's just brilliant. And then the consultant says, you're gaslighting almost, saying, you can't, you're not just a gymnastics, you're not good at gymnastics, not childbirth, gaslighting people with saying that their views weren't true, their experiences weren't true. And that was really harming for people who need to be believed during pregnancy and at all times in their healthcare. Other people desperately wanted conversations about risks and about choices, but didn't really have the information. And we don't have all the information. There's not enough information to really make informed decisions about this. And also every choice will be individual to an individual case. But then people talked about really refreshing experiences when they saw people who were aware of EDS and listened to them. So I think for clinicians, it's really important that we do listen and we do try to understand and hear people and not dismiss them. That makes a real difference. And then here we've got some stories of when people were giving birth, they had the niggly parts of the labour, and then all of a sudden they went from 0 to 60, 3 pushes and giving birth. Then they reached 10 centimetres fully dilated just 1.5 hours after the first examination. So super quick, no one's expecting it. And then in terms of the anaesthetic, people saying they still remember the thread being pulled through and the suturing and being in pain, and no one listening to the fact that the anaesthetic wasn't working, and people just not believing them because the anaesthetic works for everybody. How can you possibly feel this when I put so much anaesthetic in? It just doesn't work in some people. And some people say they feel agony and burning and ripping sensations, which is really challenging, and epidural just didn't work. And then here the trauma from partners as well, thinking about, worrying about your partner and worrying about what's going on, being shocked, horror, things going very critical very quickly, and everything looking like a war zone. quite quickly, because people aren't prepared and people are kind of shocked and panicked in those situations. And then people talked about in the postnatal time, you know, what if I'd been diagnosed before? What if I'd been diagnosed after? What were the benefits to that? Is it better not to know? Is it better to know? People reflected on that. And people said, you know, if I'd been diagnosed before, things would have, you know, not even, you know, been better, or it would have been worse. Could have had a water birth. I had my son from an episiotomy, really bad problems with prolapse, so they may have chosen something different, or a cesarean section, in light of what they knew afterwards. But at the time, decisions were made, not knowing the implications of that. And then again in caring for their babies, people were saying, you know, I tried to feed, but I couldn't hold them in the same position all the time, or when I asked for help, I kept buzzing, and I was the annoying person because the midwife or nurse couldn't get on with their job because they kept having to come to me. I wasn't lazy though, but I was perceived as lazy, but I just couldn't get out of bed, or I couldn't move myself in these ways because those mobility issues were still there. And again, talking about parenting, on day 3, people said they saw bruises and were acute. You know, there was undertones of accusations of where did these bruises come from. I don't believe they came from here, there, and everywhere. Which again is why it's really, really important to document any bruising very early on in children. And then thinking about constantly lifting your baby and holding your baby. You know, some people were reflecting on how they were subluxing their joints when they were holding their babies, and just doing general parenting skills. So from that, you'll see the team here of headstogether.com. So we've got Dr. Gemma Pierce, myself, I'm the lead midwife, and then Paul McGee. And headstogether.com was brought together as a kind of collaborative and also a repository of people doing work in this area and publishing work in this area. And you can visit headstogether.com, HEDS together, and have a look at some of the work there. But from that, really, we pulled all of that work together, and other work's going on in the area as well, to think about how we might tackle some of these issues, not just in pregnancy and birth, but in other ways as well. And from this work, we co-created with a bunch of collaborators this decision-making tool. And this is something that's freely available, freely downloadable from headstogether.com. You can download it, print it out, and put it in your medical records or your notes, or just take it with you to talk about your conditions. So it's got some of the things at the top there you can see in the bubbles, the coloured bubbles, about what you might need to know, or what someone else might need to know about HEDS and HSD, affecting 1 in 20 pregnancies, and then making decisions together. So thinking about how it might affect a pregnancy in general, and on the left-hand side, and then on the right-hand side, talking about things that are unique to you, things people can do to support you, and things that people should avoid because they make things worse for you. And again, that's totally individual, which is why that's completely open for people to write on. Then you've got that communication tool there at all times. You've also got a point of discussion. If a healthcare professional doesn't know anything about this, then this should be a starting point for your collaborative discussions and decisions around care pathways. We also co-created an infomercial, which is again on the headstogether.com website. It's also on YouTube, where unfortunately it was done during lockdown, so we're the actors in the infomercial. But it's an infomercial just giving general information about the conditions in relation to pregnancy, how you might want to use the tool, and how it might affect you and others. Then we expanded that to, on the Royal College of Midwives iLearn site, we had a small module to teach midwives how to recognise hypermobile Ehlers-Danlos syndrome, how it affects the connective tissues throughout the body, and what they might need to know. And we also use those stories, as I said, to help them with clinical scenarios. Then we wrote the clinical update, and the partnership went international. So I was then invited to join the Ehlers-Danlos Society International Consortium to do more in this area. And we're still working together now on some very exciting clinical guidelines. And we're hopefully going to be submitting those in the next couple of weeks to get them published for wider sharing and reading, so that we've co-created them together with the International Consortium, and a new load of research has been published since even then we did the clinical care considerations. So hopefully that will keep growing and keep building as we go forward in the research, as it always does. And then here are the references, if anybody wants to look through those at all. And I can share them with everybody. Other than that, I will go back to my final slide and say thank you very much for listening to what we've achieved and the journey we've been through. And please do visit headstogether.com to find out more and be in touch as and when needed. Any questions, let me know. Thank you.